Hi dear doctors, there's a very famous saying in Hindi कि दिल का रास्ता पेट से होकर जाता है. What does this mean in English is that a way to win anybody's heart passes via the gastrointestinal tract, more medically pronounced. So what is important, why I have told you this, because this is the video from which we are going to start the gastrointestinal tract pediatrics. In the systemic pediatrics, we are going to start with the GIT and of course the hepatobiliary and pancreatic system. Okay, so this is the first video in gastrointestinal tract. Okay, just a second. Yeah, in the gastroenterology, this is our first video, and let me just share with you the plan in which, how we are going to proceed. So in the first video, we'll start with the tracheoesophageal fistula. Now this tracheoesophageal fistula, for example, this is trachea, this is esophagus, so there's a connection between the two, tracheoesophageal fistula. Sometimes this connection is good, sometimes this connection might have the esophageal atresia. Okay, so tracheoesophageal fistula can sometimes present as esophageal atresia. Esophageal atresia sometimes may have a biliary atresia also. Sometimes may have what? Biliary atresia also. Okay, so basically the class 1 and class 2 are actually same, but I'm really sorry that we have written it separate classes. Next we'll discuss about the pyloric stenosis, then malrotation and Meckel's diverticulum, and then we'll have the Hirschsprung disease and imperforate anus. After that, some neonatal conditions like necrotizing enterocolitis and short bowel syndrome, and then we'll discuss some obstructive disorders like intussusception, esophageal foreign body, and we'll end up this whole part of GIT mainly with the help of some cases like colic, constipation, emesis, abdominal pain. Then some infections like Reyes syndrome, and neonatal conditions like Arazil syndrome, Klinger-Najas syndrome, Dubin-Johnson syndrome, Gilbert syndrome, Rotter syndrome. All these syndromes we'll discuss in the end. Coming on to esophageal atresia, or you can call it as tracheoesophageal fistula. Okay, so tracheoesophageal fistula, there are actually different types of tracheoesophageal fistula. Let me discuss with you different types one by one. Type A, B, C, D and E. So these are the parts of tracheoesophageal fistula. Okay, so in the first part you can see this is actually trachea and this is esophagus. Okay, this is trachea, this is esophagus. So in first part, the esophagus is also having atresia. So what is atresia? Atresia is actually you can say a malformation where the opening is not patent, the lumen is not patent, the lumen undergoes atresia. Okay, so it's atresia. So type A is atresia. Okay, so you can remember from A, you can remember atresia. Coming on to B, so what happens in B? So type B is having, of course, esophageal is atresia, and then there is a tracheoesophageal fistula before, or proximal to the esophageal segment. Okay, so what is going to happen now? This is the case here. This is the case. Okay, so it's going to open before what? Before the opening of the esophagus. So this is the B means what? That B means the esophagus is going to open, but going to open proximal to its normal opening. Okay, and then in C also there is esophageal atresia and it is going to open distal. Okay, distal to its opening. Okay, distal to the not distal but distal esophageal, the fragment which is distal is going to open into the trachea in the C part. In D what happens? In D, the proximal as well as distal both are going to open. This is the proximal one which is opening, this is the distal one which is opening. Okay, so this is like this. Yeah, this is the case. And then you have got type E. Type E is actually the H type. Type E is also called as H type because there is a H which is formed. H which is formed means this part is in the connectivity, then the trachea is there, and then there is a connection in between the two. So you can see the H which is formed properly. So the E type is actually called as H type. So I'll just quickly revise it with you what we have done. The type A is atresia. B is going to be the proximal part because the B and P looks very similar. What is the difference between B and P? This. Okay, so type B is going to be proximal, and C and D comes very close in the alphabets. So type C is actually distal. What is type D? Type D means that both, the type D and type E are very similar, you know. In one, yeah, this is one, this is second. In one, there is esophageal atresia which is still present, okay, but in E, there is no esophageal atresia. This is a fistula which is there without the atresia, okay. So coming on to one by one, we are discussing the esophageal atresia only. So what is this? This is a congenital abnormality which occurs due to abnormal communication between trachea as well as esophagus, and it is most commonly associated with the esophageal atresia. I have told you that type A is going to be pure atresia and there is no fistula. Type B is going to be fistula, proximal fistula is going to be there, and esophagus is again atresia. Then type C is proximal esophageal atresia and distal tracheoesophageal fistula, and this is the most common one. So C is the common, okay, so very easy to remember that C is the common one. Then type D is having the distal fistula, proximal fistula and esophageal atresia. So D equals to di means both means there is proximal as well as distal fistula which is going to be there. Proximal plus distal fistula which is going to be there. And what about type E? It is the H type fistula, there is no esophageal atresia. So what happens is, see, whenever we talk about all these things, we talk keeping in mind the most common one, and the most common one is like this. This is the esophagus, and you know, this is the distal esophagus, and the distal esophagus is going to open into what? That's going to open in the trachea. It's going to open where? It is going to open in the trachea. So now what is going to happen? Yes, what is going to happen? There will be frothy saliva. Okay, there will be what? There will be froth in the saliva. There will be froth which will be coming in the saliva. Why do you think there will be froth which is coming in the saliva? Because, my dear friends, now you can clearly understand that the air and the saliva are going to get mixed. Okay, the air and saliva are going to get mixed, so there will be froth in the saliva. Of course, because what I should say, whenever you will try to feed the baby, please understand, whenever you will try to feed the baby, it is going to, first of all, it is going to get aspirated. Okay, it is going to get aspirated, recurrent aspiration pneumonia, and because it is going to the trachea, there will be coughing, there will be choking, and there will be cyanosis on feeding. So 3 C's are important. So actually the C is actually very, very important when it comes to your tracheoesophageal fistula, because C is the most common type also. Then there are 3 C's as well which are important. And of course, whenever you will try to pass the nasogastric tube, the nasogastric tube will not be passed, rather than it's going to coil here. So there will be inability to pass the nasogastric tubes, and it's going to coil in the upper pouch on the X-ray. And because of a lot of air being present in the trachea, that's going to go in the stomach, and the abdomen is going to get distended. Abdominal distension is going to be there if there is a distal fistula which is present. So what is the investigation? Of course, the tube is going to stop in the upper pouch, NG tube. And now we will discuss about the important thing, that is your X-ray. Now what happens in X-ray, please understand that, you know, in type A, there is no connection between the esophagus and the trachea. So there is no excess amount of air which is going to go in the stomach. There is no excess amount of air which is going to go into the stomach, and that's why the stomach is going to be a gasless abdomen. There is no gas which is going to be there. But you know, if you talk for type C and type D, what is going to happen? There is a connection between the stomach and the trachea. Okay, there is a connection between the stomach and the trachea. So the stomach will be full of air. So the stomach is going to be full of air, the stomach is going to be full of gas, and this is going to show the gas in abdomen. Okay, so I think the things are very clear to you. And of course, the risk of aspiration is there. The contrast studies are rarely used. Okay, so sometimes, you know, they used to tell in the olden days that pass the barium. Okay, so do the barium swallow, okay, in order to see where is the position of esophagus, but we don't do that. Why? Because there is a high risk of aspiration. Now this entire thing is associated with a vectral abnormality. Vectral is not my mnemonic, but it's a standard mnemonic. So vectral is this vectral. So V for there is a vertebral defect, A for anal atresia, C for cardiac defect, of course T is tracheoesophageal fistula, renal abnormalities, and the limb abnormalities. I know this seems to be very easy, but this is not easy.
to remember all these things. So I'll just draw a picture. So these are the two limbs. So one is the limb abnormality. Then if you go ahead, then you are going to see what? There you are going to see two kidneys. So renal abnormality is going to be there. Then of course, and this is the position for your anus. So this is the lower half of the body which you have to understand, anal atresia. Then more above you will see what? You will see the vertebrae, so vertebral defect, and you have heart above. So this is the cardiac defect which is going to be there. So what we are supposed to do? See, first goal, the primary goal is to prevent the aspiration. See, esophagus is atretic, so most of the contents are going to go from the esophagus into the trachea, and we have to prevent that. So in order to prevent that, first of all, we are supposed to stabilize the patient. How will you stabilize? Stabilizing means you will give an upright position, you will do the suctioning of the pouch, you will give the IV fluids. Okay, this is actually the most important thing. So whenever the patient is coming, the very first thing is give him an upright position in order to prevent the aspiration. You do the suctioning, whatever the secretions are there in the esophagus, you have to remove those secretions, and of course you have to give the IV fluids because the baby is not able to feed properly, so baby is going to be dehydrated. But the definitive surgery is going to be a surgical repair. So what you will do, the fistula, you have to ligate the fistula, and once you have ligated the fistula, you will do a end-to-end esophageal anastomosis. You will do what? End-to-end esophageal anastomosis. Let me just show you. So this is what? This is nothing but the esophagus, this is nothing but the trachea. So and this is the other end of the esophagus. So what will you do? You will ligate this part. You ligated this part, the fistula, and then you are going to join these both two ends. You are going to join them. So this is end-to-end esophageal anastomosis. If gap is too long, yeah, it happens. If the gap is actually too long, then what to do in that case? In that case, you are supposed to do a gastric pull-up. Either you pull up the gastric thing, or colonic interposition, that you will take a graft from the colon and interpose between the two. You do a gastric pull-up. Alright, like that you can do, and it's a staged repair. That means first of all you will allow the other end, the lower end of the esophagus to come, and then you are going to fix it. Okay, and on this note, I just want you to comment down in this comment section, what do you mean by Focher's operation? Okay, this is a important previous year question for NEET. What is a, not for NEET actually, for any competitive exam for that matter, what is Focher's operation? You have to check. Now what are the complications? So see, once you have done the anastomosis, this anastomosis may show you a leak, or may show you some strictures, or it may show you the formation of fistula once again, or it can show you what? It can show you tracheomalacia, and of course the recurrent chest infection and GERD. See, what happens is, now why GERD is going to occur? Because the esophagus, it's a very highly muscular thing. Okay, normally esophagus is a very highly muscular thing. So if you are stretching the muscle, okay, so what happens is you have to stretch now. If this was your normal this thing, so you, in order to pull this lower end close to the upper end, you have to pull and you have to stretch. So if it is stretched, the wall is also going to stretch, and of course the wall is not going to get closed properly. So it can cause what? It can cause GERD. It can also cause a pressure on the trachea, and that leads to the tracheomalacia. And because of the, again and again, what you are seeing is that there are infections which are going to occur. Why? Because a lot of I should say a lot of stuff is going from esophagus to your trachea, and that causes what? That causes the recurrent chest infections. This picture we have already discussed, and now this is the time to discuss this X-ray image. Can you see there is a coiling which is happening? Okay. Now coming on to the next part, the second part of this huge topic, and this part is called as biliary atresia. Now what is biliary atresia? See, if you see in this part, in this image, this is extremely important image. So what happens normally, you have got a common hepatic duct, then common hepatic joins with the cystic duct, and that leads to the formation of common bile duct. So what happens is different parts of the bile duct can show atresia. Atresia means narrowing of the lumen. Okay, atresia is nothing else but narrowing of the lumen. Atresia is nothing else but what? It is the narrowing of the lumen. Okay, it is the narrowing of the lumen which is going to be there. So what is important in this, please understand, you have got a cystic duct, a common hepatic duct, a common bile duct, like that. So in type 1, there is the common bile duct which is going to undergo atresia. In 2A, it is common hepatic duct which is going to do it, going to undergo atresia. In 2B, both of them, common hepatic also, common bile also, and in fact the cystic duct is going to undergo atresia. And in 3, the intrahepatic ducts along with the common hepatic, along with the common bile, along with the cystic duct, everything is going to go what? Atresia. Now see, understand, it's very simple. Whenever you're writing 2B and 3, you just add 1. So if you add 1 in 2B, that's going to be 3. That means 3 structures are involved. Starting from below to up, common bile duct, cystic duct, common hepatic duct. In 3, you add 1, that leads to 4. That means all the 4 structures are involved. Cystic duct, common hepatic duct, common bile duct, and in fact the intrahepatic duct also. Coming on to 1 and 2A. So what is there in 1? 1 is going to be the common bile duct. 1 is going to be common bile duct, and 2A is going to have common hepatic duct. Okay, bile duct and as well as common hepatic duct. These both are actually important. Okay, so this is one thing which is extremely important and every medical student should be aware about. So what is happening? Generally, there is a progressive idiopathic. Idiopathic means the cause is not yet known. Okay, no cause actually. Idiopathic destruction of the extrahepatic biliary tree. Mostly extrahepatic biliary tree is going to be there. But yes, as I have shown you that in the 4th stage, it can be intrahepatic also. Okay, it can be what? It can be intrahepatic also. Okay. So what happens is, in 4th to 8th week, because of the obstruction, this is going to mimic the neonatal jaundice. Okay. Occasionally, very rare cases, it may show you this in less than 2 weeks, but mostly because of the obstruction, there's going to be neonatal jaundice. There is jaundice. Okay, jaundice is going to be there, and there is going to be a dark colored urine. Okay, there's going to be a dark colored urine. I mean, urine will not stain the diaper yellow. There is a dark color urine which is going to be there. Why? Because there is no bile, there is no urobilinogen, and there is no yellow color which will be imparted to the urine. Okay. And yes, of course, there will be hepatosplenomegaly. Why there is hepatosplenomegaly? Because there is obstruction and most of the bile is going to be there in the intrahepatic biliary tree only. Can you understand? The most of the bile is going to be here only, intrahepatic, because there is obstruction, and that's why there is a hepatomegaly which is seen in this case. There is heterotaxy with polysplenia. See, this is an association which is important. Heterotaxy with polysplenia means what? See, heterotaxy is something. Hetero means different, taxi is arrangement. So different arrangement means abnormal arrangement of thoracic and abdominal organs along with the left-right axis of the body. So abnormal arrangement is sometimes seen. So it's just for an MCQ purpose. If you can remember, please do remember this. In order to see where the obstruction is, we will do the abdominal USG. And in USG, sometimes you will have your absent common bile duct, sometimes you will have your absent gallbladder, no dilatation. This is also some of the things which have been seen, so that's why it's important. And this sign, it has been asked, like this is a favorite question of the examiner. If he wants to ask one question from biliary atresia, this is the most important question. I'm putting multiple stars over here because this is important. There is a sign which is called as triangular cord sign. Triangular cord sign. Okay, what is this triangular cord sign? I think I've got a picture also. Let me just, yeah. So what is this triangular cord sign? See, so triangular cord sign means that, there are 3 components of what? Of porta hepatis. Okay, so there is 3 components. Can you see what are the 3 components? One is going to be bile duct, then portal vein, and hepatic artery. Okay, so there is bile duct, there is portal vein and hepatic artery. So what happens is that because the bile duct is obstructed, okay, the bile duct is obstructed, generally they are not very much visible, but because it is obstructed, it is going to get swelled. The bile duct is going to get swelled, and that's why all these things, the bile duct, the portal vein, the hepatic artery, you will see a an area. Can you see this this black area, right? You can see this black area with these two small dots. So these will also be visible because of the swelling. So that's why it is called as what? It's called as a cord. Cord because cord is a thick structure. So cord is what? Cord is a thick structure. So very simple, triangular cord, thick structure, cord will be visible, triangular cord sign. Now again another question which is important, which type of fibrosis? Again this is also important. Which type of fibrosis is seen? So of course, you know, because of a lot of bilirubin being accumulated, there is a fibrosis which is going to occur. And which is the fibrosis? It's a periportal fibrosis which is going to be there. We call it as PP fibrosis. Okay, PP fibrosis. Both the P's, if you join them together, it leads to the formation of B. So PP fibrosis is seen in the B, that is biliary atresia. Okay, there is biliary atresia, PP fibrosis. And what is the gold standard is, you put a cholangiogram, you put a camera inside the gallbladder to see what is happening. So cholangiogram, not in the gallbladder, actually in the biliary tree itself. So that's the gold standard one. So yeah, so what is the management? So before coming on to management, you know, there are different biopsy features seen in the different conditions, different diseases. Like biliary atresia shows a PP fibrosis. So biliary atresia showing a PP fibrosis, periportal. Whereas in some cases of alpha-1 antitrypsin deficiency, you will have a PAS. PAS is a dye. Okay, PAS is nothing but a dye, and PAS will stain it, and there is a diastase resistant granules. Okay, dye and diastase resistance granules in what? In the alpha-1 antitrypsin deficiency. And in Alagille syndrome, you will see a bile duct paucity. So bile duct paucity means there will be nothing coming out from the bile duct. So A and B come together. Okay, so Alagille syndrome will show you what? Will show you bile duct paucity. In antitrypsin deficiency, please remember that you have to remember PAS positive and diastase resistance granules. So how will you manage? What will you do now? See, so what happens is, now the bile duct is obstructed. There is no bile duct which is coming out. So how to get rid of that obstruction? So we do hepato, porto, enterostomy. Hepato, that means of course the hepatic vessels. Porto, that means the portal vein. Entero, that means you are connecting the what? You're connecting the gut also. Stomy. So you are, you know, the damaged bile ducts, the blocked bile ducts, you are just going to get rid of them. How? By connecting what? By connecting the small intestine directly to the liver. Okay, the small intestine will be connected directly to the liver. So now the liver can pour the secretions directly into the small intestine. So this is the hepatoportoenterostomy, and this hepatoportoenterostomy is called as 𝗘𝐶𝗵 operation. It's called as which operation? Which procedure? 𝗘𝐶𝐵 procedure. And of course, ursodeoxycholic acid is given in order to get rid of the the obstructed bile. And because this is a condition which 𝗘𝐶𝐵 surgery is good, actually it's good, but then liver transplant is also required in 60 to 80% of the cases. So this was the question which was asked. So which of the following surgeries should be performed? So the surgeries which should be performed is actually the 𝗘𝐶𝐵 surgery. Which surgery? It's the 𝗘𝐶𝐵 surgery. So that's it. And the best outcome is going to come if the 𝗘𝐶𝐵 is performed in less than 60 days. All right. And if not performed, then of course the portal vein is going to be under pressure, and that leads to portal hypertension and the complications associated with it, like variceal bleed, ascites, everything. Why there is portal hypertension? Because that is going to be compressed by the accumulation of the jaundice, accumulation of the bilirubin and the dilatation of the biliary tract, one thing. And of course the liver diseases are going to happen. So normally liver is responsible for secretion of the coagulating factors. So if there is no coagulating factors, there will be coagulopathy, there will be pruritus. Why there is pruritus? So the bilirubin is going to get accumulated in the skin, and once it's going to get accumulated in the skin, it is responsible for causing the pruritus. Pruritus is nothing but the itching which is going to be there. All right. So these are the most important things which we have already discussed. So thank you so much for joining us in the atresia videos. We are done with the esophageal and biliary atresia. Thank you.